Thank you very much. Thank you for the invitation. It's an honor to be here, and it's an honor to be back to the real world. So in my presentation, I will be speaking of, I will be concentrating on autoimmune diseases. Okay, this is how this works. So when it comes to autoimmune diseases, we have two major questions. The first question is what are the major factors underlying the autoimmune diseases? And then the next one is what are the diseases or what are the disease groups to be speaking of? And the third one is that why does a PKD work and in these conditions and how we can reverse these conditions. So the same here, I think I do not have a pointer. Okay, anyways, so the first factor, so we believe that these are the three major factors underlying the development of autoimmune, generally chronic diseases. First one is the overconsumption of carbohydrates, which is resulting in obesity, type 2 diabetes, and any metabolic syndrome-related diseases. And if a patient starts applying a PKD, periodic ketogenic diet, this will reverse the overconsumption of carbohydrates, and that's the mechanism of action how this works. Then the second underlying cause is the foods that are causing an increased intestinal permeability and an increased permeability of other membranes within our body. And this is the cause that is responsible for a wide array of autoimmune diseases and cancer. And since the PKD is excluding these food items, there is a way to reverse this condition by this exclusion. And the third one are the food additives, which may be the major factor behind epilepsy, panic disorder, and cardiac arrhythmia. The PKD is excluding these items, therefore these conditions may be reversed by eliminating this third factor. So this is of course not a fully one-to-one correspondence because there may be factors that may be resulting in more diseases or disease groups, or behind one single disease like epilepsy, there may be carbohydrate overconsumption and food additives as well, but this is a general scheme that connects a cause and the resulting disease. Oops. Okay, in this presentation I will be focusing on this middle one, foods that are causing a pathological permeability of the intestines, and these are the autoimmune diseases and cancer, and here I will be concentrating on the autoimmune diseases. We are using a diet that we call the PKD, the periodic ketogenic diet, and this is basically a meat-fat-based diet that is based on four-legged animals. There is a specific ratio between the meat and the fat, and it also includes organ meat. So this is the easiest way how we can define this diet. And this is basically two forms of the diet. On the left, you can see a full meat-fat-based diet that is lacking anything else, any plant food component. And on the right, you can see a more relaxed version that allows for some vegetable or some fruits in moderation and only certain ones. There is a continuum between the two. So the one on the left is for those who have an autoimmune disease or any more complicated diseases or coming from a background that involves medications. This is the way to start with. The right one is for those who just want a diet for prevention or for those who already recovered from a more serious disease. The intestinal permeability is, which is also called the leaky gut, is a key. Is it better? Okay. So the intestinal permeability is a key behind autoimmune diseases. In order to understand the concept, you need to know that the intestine has a dual function. It is functioning as absorption, and it is also functioning as a barrier between the gut, between the content of the gut and the rest of the body. And the combination of the two is resulting something called selective permeability. So any transport of any nutrients or food items is occurring in a very selective way and a highly regulated way. The first question is what is affecting intestinal permeability, what are the consequences, and how we can reverse an increased intestinal permeability. It has been acknowledged that if we could reverse an increased intestinal permeability, then we were able to cure a wide array of autoimmune diseases. So this was basically concluded in this article on the right. But there has been no really good idea on how we can indeed reverse increased intestinal permeability. There have been a few experimental trials and a few other ideas from somewhere else, but none of them proved to be a really good tool to reverse intestinal permeability. And this includes probiotics, prebiotics, colostrum, FODMAP diets or other diets, fecal transplantation. None of them really worked. Okay. For example, here is this study from 2014. This was a study where they used a regular paleo diet, which actually looked like here on the right upper corner. This is a regular paleo diet. When they looked at the effect of this diet on several health parameters, including intestinal permeability and inflammation level and many others. And it was found that the diet had a positive effect on weight, glucose control, waist, circumference, so basically metabolic parameters, but there was no positive effect on increased intestinal permeability or the inflammation level. So this is crucial because inflammation and the leaky gut is at the core of the autoimmune diseases. If you can read that any diet has a positive effect on some parameters, it doesn't mean that the same diet will have the potential to recover any more serious autoimmune diseases. And this is what we can see in our practice too. So several benefits, but if it is not affecting the core of the diet, that it will not cure autoimmune diseases. So actually the very first evidence that elevated intestinal permeability was normalized by any intervention came from our case study here on the right. This was published in 2016. This is how the intestinal permeability is measured. We use a test that is called the PEG or PEG test for measuring intestinal permeability. You can see that the first measurement was done at 4 months on a diet in a Crohn's disease patient, a very advanced Crohn's disease patient. He was just before a surgery after a long course of the disease. You can see that the first measurement in red was still high, and the second measurement that was done at 10 months on the PKD was already back to the normal range. So basically the PEG test is using a solution of the so-called PEG molecules with 11 different sizes, and they calculate the recovery of this molecule in the urine, and that's how the permeability is calculated, and everything is plotted on a graph. Anything that is outside, anything that is above the upper dotted line is regarded to be high. So it is expected that intestinal permeability in an ideal situation goes back to the normal range, which is between the two dotted lines. So going back to the case, along with this reversal of elevated intestinal permeability, it was found that the ultrasound picture of the of the intestine normalized. So this is basically about thickening of the intestine, which basically means inflammation, edema. This normalized. Then we followed the patient with laboratory blood works, and we saw an improvement and actually a complete normalization of the laboratory blood parameters, including inflammation levels. The patient also became symptom freedom, and medicine freedom was achieved too. This is a more detailed representation of the inflammation level. On the top, you can see the treatment that the patient was receiving. So here you can see the first part that was done while doing a standard diet, and the second part on the right, you can see how PKD affected inflammation levels. You can see CRP and ESR. Maybe I can. Can I just? Sorry. Thank you. Can you help me go in the... Thank you. Sorry, it was just so uncomfortable.
This one?
Oh yeah, more or less. I go back. Thank you very much.
Don't look at the screen. Just look at the monitor.
Okay.
The crowd. Then we can hear you.
Okay, I will do. So we have the two major inflammation markers, CRP and ESR, and as you can see on the standard treatment, that also included anti-inflammatory treatment. The inflammation levels were higher as compared to the PKD, were much fluctuating too. And this on the right side show what has happened after the publication of this case study. You can see that inflammation level went further down. Currently, this patient is one of the longest, is the one with one of the longest follow-ups. He is on the PKD for 7 years. He is about to finish medical university, by the way, and he's completely disease-free and medicine-free. So he's about to finish medical university, and he already knows how to recover a Crohn's disease. Okay, we can also say that this case study was a milestone case study because based on the results of this case, the PKD was included in the Polish Pediatric Gastroenterology Society guidelines as one of the potential diets that may have a positive effect on Crohn's disease or any other inflammatory bowel disease, which is kind of a big thing because these case studies or these cases do not really get their way into the standard academic medicine. Okay, back to the PEG test. We have been measuring PEG for measuring intestinal permeability since 2015. Initially, we had a collaboration with the Biolab company in London. And then from 2017, we have been working on developing our own furthered methodology with a PEG test. And unfortunately, our colleague Peter Meris passed away at some point, and then we started doing another collaboration with the Department of Applied Chemistry in Debrecen, which is another medical university in Hungary. Collectively, we have been measuring several hundreds of PEG tests for intestinal permeability, most of which we also know the background, so what the disease is associated. So we know many data that is being associated, and we can do a few conclusions. What we can conclude is that if the PKD is properly applied, then the initially elevated intestinal permeability normalizes. Here we can see healthy controls. you can see the first measurement that was done while still following the initial diet, which was the which was the Paleolithic diet in the first subject, and in the second and in the fourth subject, it was the Western type diet. You can see that intestinal permeability was high in all 3 cases. Then patients or subjects were started on a PKD, and as you can see, 3 or 4 weeks later, intestinal permeability went back to the normal range. We have a third measurement here in this first subject that was done at 1 year on the PKD, and it is farther down. And this is happening like a rule if somebody is indeed following PKD, regardless of the background, almost regardless of the background where the patient is coming from, and I mean disease-wise, or whatever other diet the patient may have been following. So these are the conditions that we have the most experience with, the most patients, and these are the ones I will be speaking of and showing you data about. Here is a second case. I already showed you one. This is a second case. This was a more complicated case as he had a non-Hodgkin lymphoma with several complications. Then he was diagnosed with Crohn's disease in 2005. He developed multiple complications, including multiple abscesses, and he received several surgeries because of these abscesses. In 2016, he started a PKD, and he achieved complete recovery. He became completely symptom-free. The abscesses healed in a few months, and he's still medicine-free. So let's look at the inflammation. Again, on the left-hand side, you can see the CRP and the ESR measurements that were done while on the standard diet, standard treatment. On the right, you can see PKD and no medicine. As you can see, data or measurements are much higher on the standard approach as compared to the PKD. Here is a statistical comparison of the most important laboratory parameters. There are even more, but these are the most important ones. And out of these ones, I will show you these 3. First one is the WC, white blood cell number, which it can also be regarded as one of the inflammation markers, and it went back to more or less the half. Then we have the CRP. The CRP went back to 1/4 of the original average. And then we have the folate, the third one. The folate increased by 3-fold. And this is something interesting here, because this is something that you cannot achieve with a regular carnivore diet, because in order to have a good folate level or catch up with the folate, you need to eat organ meats, which is a must to do on the PKD. And when I'm speaking about folate or any other vitamins, I also mean many other related vitamins, because vitamin levels are correlated with each other. So when we are speaking of folate, we should also keep in mind that we are also speaking of vitamin C and a few other vitamins that are collectively reflected in folate and vitamin D levels. Okay, on to type 1 diabetes. So this is a quick overview to show you how PKD relates to the standard treatment and any other low-carb approach. So let's start with the standard care, which is, of course, life-saving, but it is not a cure, actually. They are substituting something that is missing. They are substituting a hormone, but it is not a cure. And standard academic medicine is regarding type 1 diabetes as incurable because of this. Then we have a more general low-carb, high-fat diet, the content of which may be quite variable. We can say that this is providing a partial cure. It is resulting in a much better glucose control. It is allowing for decreasing insulin, and it is also able to prevent hypoglycemic episodes in a patient. So let's call it as a partial cure. If you look at the column with the PKD, you can see that the benefit list is longer. In addition to the 3 major benefits with the low-carb, high-fat diet, we can also achieve inflammation control, and we can achieve preventing long-term complications that usually come along with type 1 diabetes. And on the top of this, we can also say that the PKD is curative in new onset type 1 diabetes cases because it is able to restore the own insulin production. This may not be the case with those who have a long-lasting diabetes. So these are the first 2 published cases with a PKD where we showed that there is a possibility to restore the own insulin production. It is not possible with any other intervention, as far as we know. We have showed this by measuring the so-called C-peptide, because the C-peptide is signifying the own insulin production. Here you can see the pro-insulin, which is cleaved into the C-peptide and the insulin in a 1-to-1 ratio. That's why it is possible to measure C-peptide instead of measuring the insulin. So we are concentrating on C-peptide and how C-peptide changes after starting the diet. This is how glucose levels were after starting the PKD. You can see that glucose levels were very stable and low as compared to the insulin regime and high-carb diet. This is sustainable as long as the patient is following the PKD. What we see in the long term is that there is an increase, or at least a stabilization of the C-peptide. Usually there is an increase as compared to what was measured at diagnosis onset. So these measurements here are a few months apart from each other. There is an increase in most of the cases. Here are other cases where the same thing happened. But there is a minority of patients where we realize that there is an apparent drop in the C-peptide. And interestingly enough, this was seen in those patients who very highly adhere to the diet. So we were wondering whether this effect is because of eating a lower and lower and lower carbohydrate content diet, and that's why less insulin is produced, that's why less C-peptide is measured. So we need to find out how we can distinguish with this phenomenon from the autoimmune destruction of the insulin production, producing cells in the pancreas. So for this reason, we introduced another measurement, which we call the stimulated C-peptide. So we measure 2 C-peptides, one fasting, and which is paired with a stimulated one. The stimulated one only means that the patient is taking a regular breakfast with him or her and is eating the PKD breakfast and then goes for a second measurement. And as you can see, the C-peptide, which is pictured in red, is always higher than. This is, of course, not a surprise, but this is indicating that this is a very good tool to measure the both, because the combination of the two is providing a much real picture of the own insulin production. Usually we measure the stimulated C-peptide 1 hour after having the breakfast. This is a case when we measured it at 1 hour and 2 hours, so there is a further dynamics that may be happening. But anyways, the interesting thing is that the stimulated C-peptide is always in the normal range. The red dotted line is representing the low end of the normal range, which means that if there is a need to produce insulin, these patients are able to produce their own insulin. And a few other cases, these are on the left-hand side, this is a child and an adult woman. C-peptide is preserved, plus there is an additional increase when we measure stimulated C-peptide, and this is the case basically with each and every newly diagnosed type 1 diabetes patients. Onto the LADA, late onset autoimmune diabetes. This patient was first put on a standard approach, as it used to be the case. Then he, just by himself, found out that the carnivore diet would help him, so he moved on with the carnivore diet, and in another 2 months he started with the PKD, and along with this he gradually decreased his insulin on his own. We started our regular 2 weeks follow-up program, so we always have a follow-up with those patients who we are consulting with, because there is a need to give a close surveillance and the feedback to these patients. Here you can see the glucose and the ketone levels during the 2 weeks. As you can see, glucose was relatively low, and the patient achieved and maintained ketosis. Currently, this patient is still insulin-free already for 2 years. This is another representation of the glucose levels. So here you can see 4 months. The first half is the carnivore diet, the second half is the PKD. Here you can see the black bars are indicating the insulin doses that were used, and once on the PKD, the patient stopped using the remaining insulin. If you look at the colors, the red colors are representing the high blood glucose levels, the blue ones are representing the lows, and the vertical scale is representing time of the day in a 24-hour resolution. As you can see that the red color is fading into blue, which is kind of reflecting a tendency towards having lower blood sugar levels, despite of the fact that the patient stopped using insulin. So we can say that there is a further improvement after starting the PKD, and this may last as long as a few months. The recovery is going on, obviously. Here is another phenomenon on the left bottom side. Do we recognize what this phenomenon is? Left button, this red patch. Left upper, right patch. This is don't phenomenon. And we very often see this with a carnivore diet, or in patients who are taking excess insulin, more insulin than they need, or anybody who usually have a higher blood glucose level, and this phenomenon also fades away if somebody is closely following the PKD. Okay, this is how the C-peptide production was. You can see both fasting and stimulated C-peptide remained stable. Okay, let's go on with the autoimmune I think this is a hypothyreosis, like Hashimoto. In this case, this patient already had Hashimoto for 16 years, and she was on thyroid medication for 12 years. She had high anti-TPO levels. And these are the treatments, alternative treatments that she was trying out without a major effect. So she was started on the PKD, and here you can see the incoming numbers and score of the symptoms as we see at our interface. We do have an online interface to follow up patients. The patients have another interface to look at. Anyways, this is the summary of the incoming data across the 2 weeks. As you can see, both glucose and ketones were stabilized in the target range. The target range is having a blood glucose levels of no more than 4.5 or no more than 80. Blood ketones should be at least 2. As you can see, the weight was going down. The patient already started a PKD a few weeks before. even if this was not a perfect version of the PKD, but symptoms already improved, and there was a minor further improvement while we were doing the follow-up. And on the right bottom corner, you can see how levothyroxine was tapering down. Thyroid supplementation is only possible if you have a day-by-day feedback from the patient, and it is assisted by laboratory blood works. At least 2 laboratory blood works are needed. Here is a small disclaimer on the bottom. Hypothyroidism cases may be very different. One may be very different from another one, depending on where you are coming from, the dose of your medication, the type of your medication. So do not try to repeat this, because this may not apply for you if you have hypothyroidism. And the opposite disease, the autoimmune hyperthyroidism, Graves' disease. This is a newly diagnosed Graves' disease with high Graves-related antibodies. She was immediately started on metamizole sodium. This patient also had other autoimmune conditions, and these are the symptoms: strong palpitations, elevated heart rate, autophony, popping of the ears, tightness of the throat, and sleep loss and anxiety. And these are the results during the 2 weeks follow-up. As you can see, ketones elevated in the target range, glucose remained relatively low. And here are the resulting symptoms. As you can see, there is some fluctuation in the symptom, but overall there has been a decrease. You need to know that with the Graves' disease, 2 weeks is not enough. To recover from a Graves' disease, it takes a much longer time as compared to autoimmune hypothyroidism, so a longer follow-up is needed, and many more blood works are needed because these measurements are changing much slower. So you can see that originally the TSH was very low. It was suppressed, as it used to be the case with Graves' disease, and it took 6 weeks before the TSH went back to the normal range. So anything that is lower than expected or ideal is highlighted in blue. Anything higher than expected is highlighted in pink. So it took 6 weeks before the TSH went back to the standard normal range. And in the top row, you can see how the metamizole, the anti-Graves medication, was tapered down. Each tapering steps should be assisted again by day-by-day feedback and the blood work. So a visual representation of the same thing. In orange, you can see how metamizole was tapered down slowly, gradually, and alongside how TSH went back to the normal range. And this was possible only, of course, by doing a PKD. In itself, it is not possible at all. Okay, last disease, juvenile rheumatoid arthritis. This was a young child, 6 years old. She already had a few years of disease history. When we first met her, she was on 2 medications, Enbrel and methotrexate. She was taking supplements, and she was following a standard, all the gluten-free diet. At the start of the PKD, her mother reported that she's getting tired very quickly. She had hip and toes pain. Her joints were swollen. She had edema throughout the body. She had skin reaction where the injection was given to her. She was very nervous. She had elevated pulse, and she had restless legs during the night. So this is one disease and a list of symptoms. At 2 weeks, the mother reported that the energy level is much better. She reported that there is much less pain, no edema, the swollen knees is gone. At 3 weeks, she reported that the small child is not complaining about anything. And this is what the blood works showed. The control blood work at 1 month. We are always doing a comprehensive blood work at 1 month after starting the PKD, show that each and every parameter was in the expected range, which is a good feedback that the child was adhering to to what she was expected to follow diet-wise. In the middle, you can see that here are elevated liver enzymes, which was very likely the result of the medication that the patient was prescribed. So these prescription medications mean a chemical toxicity. Since she was doing PKD, this enabled tapering down the medication, and as a result, liver enzymes normalized too, which was good news for her caring physician. Why it is important to use a diet approach if you have an autoimmune disease? First, because there is no other cure for autoimmune diseases. Autoimmune diseases are regarded as incurable. And the second reason is that if you have one autoimmune disease, you are very prone to develop a second one. So here you can see how autoimmune diseases follow each other in children. So the first autoimmune condition we often see is just an eczema. We do not care about it. Then the patient or the small child may develop allergy. And then a third one, asthma and Crohn's and type 1 diabetes, or type 1 diabetes and Crohn's. This is a scenario that we very often see in children as they are growing up. Okay, this is just a quick summary of what you can achieve with a PKD in autoimmune diseases. So the PKD, if properly effectuated, holds the autoimmune process that is going on, that has been going on. It is resulting in a complete recovery in most autoimmune conditions. And I only showed you a few diseases and just a few cases. But when I am presenting the case, there are dozens of other successful patients on which I am basing my conclusions on. In type 1 diabetes, those with a new diagnosis, insulin freedom is possible, and it is possible to restore the own insulin production. In long-lasting cases, it is possible to prevent long-term complications, and it's possible to decrease the external insulin. You will be able to enjoy the benefits of the PKD. So far, you are following the PKD. This may sound obvious, but when we are interacting with patients, we have to remind patients all the time that this is the case. And there may be some cases or diseases less severe or more or less recovered diseases where a broader version of the PKD may be enough. Okay, and I would like to take the opportunity to introduce you this book, which came out just recently. This was put together by my colleague Natalie Daniels, who is one of our dietary assistants. So she compiled this book, which is a practical guide to PKD for those who are about to start or would like to learn more about the PKD. And this is a very, very practical book. So this will be hopefully of help those who need something like this in their own kitchen. I have a copy with me, so you can have a look at it if you have the time. Yes, and I think that's it. Thank you very much.
Thank you, Dr. Sofia Clements.